Good morning to all. My next talk for discussion is on hypokalemia and hyperkalemia. So this is also a very important topic, and it's a high probability question in the upcoming theory exam. And it is very important from a practical perspective because in the OSCE stations, it is high likely to be discussed in ECGs and in drugs, where anti-kalemic measures can be kept or potassium chloride itself can be kept, and there can be further discussion from that. So it is important to know about this in detail, not only from the exam perspective, but on a regular day-to-day work basis also. So I'll be discussing on the introduction, the causes, the clinical manifestations, and the management. So coming to introduction, hypokalemia is defined when the serum potassium levels is less than 3.5 milliequivalents per liter. So you can quantify the severity into mild, moderate, and severe, where mild is between 3 to 3.4, moderate is between 2.6 to 2.9, and severe is less than 2.5. And hyperkalemia is defined when the serum potassium is more than 5, and that also can be quantified into mild, moderate, and severe, where mild is between 5.1 to 5.5, moderate is between 5.6 to 6, and severe is more than 6. The important thing to note is that hypokalemia is usually well tolerated, but hyperkalemia can be a life-threatening condition. And it is also important to note both these dyslipidemias can predispose to cardiac arrest. So coming to the etiology for hypokalemia, it can be because of decreased intake in states like starvation or because of redistribution into cells, which can be classified into four parts that can be hormonal, anabolic states, acid base, or others. Under hormonal, the most common cause we know is due to insulin. It can also be due to increased beta 2 activity, the use of salbutamol, levosalbutamol, terbutaline. And in inflammatory states like post-MI, where there is a high sympathetic activity, in that itself, increased beta 2 receptor activation can lead to hypokalemia. And along with post-MI states, traumatic brain injury also can lead to this condition. The other less common causes are alpha adrenergic antagonist use, thyrotoxic periodic paralysis, and sodium potassium ATPase stimulation causing drugs like thiophyllene or caffeine. Under anabolic states, in conditions like administration of vitamin B12 or folate administration, where there is an increase in RBC production, or administration of granulocyte stimulating colony stimulating factor, rather, sorry, rather can be increased WBC production, administration of total parental nutrition and refeeding syndrome, where there will be also concomitant decrease in phosphorus and magnesium levels. So in these situations also there can be hypokalemia. Under acid-base status, metabolic alkalosis can itself cause hypokalemia, and it can also be vice versa. And other states like pseudohypokalemia and hypothermia also can lead to hypokalemia. And under increased losses, it can be either renal or non-renal. Under non-renal, it can be because of GA losses like diarrhea or vomiting, and skin losses in the form of sweating. And under renal causes, it can be classified as two parts. One, there can be increase in distal flow, that is use of diuretics or any salt wasting nephropathies, or increased secretion of potassium in the form of mineralocorticoid excess that can be associated with Conn syndrome, Cushing syndrome, Bartter syndrome, and Gitelman syndrome. One of the common causes we know on a routine ICU basis, but we don't know the rationale behind it, is magnesium deficiency. The main mechanism how it causes hypokalemia is one, it has an inhibitory activity on the sodium potassium ATPase pump. So it reduces the influx into the muscle cells and it also causes secondary calurisis. How does it cause this? It causes an exaggerated potassium secretion in distal nephrons via the ROMK channels. That is the renal outer membrane potassium channels. So the easiest ways to remember the etiology is one, it can be because of decreased intake, increased excretion, and redistribution. And secondary calurisis can also be seen in renal tubular acidosis type 1 and type 2 and use of penicillin derivatives. So, and other rare causes of hypokalemia are antipsychotics like quetiapine or risperidone, cesium intoxication that is seen post chemotherapy, or barium intoxication with food contamination. So, if at all we don't find an adequate etiology in our history, then these causes can be considered. But these are very uncommon causes of hypokalemia. In barium intoxication, it is mainly because of systemic activation of the leaky potassium channels causing decrease in the systemic levels. So coming to hyperkalemia, the first important cause is because of redistribution out of the cells. So here it can be attributed to acidosis, can be respiratory or metabolic, then hyperosmolar states like hyperglycemia or mannitol, beta 2 antagonist usage, especially non-cardiogenic, non-cardioselective agents, use of digoxin, succinylcholine, hyperkalemic periodic paralysis, and cell lysis that can be associated with hemolysis, rhabdomyolysis, tumor lysis, and transfusion of whole products. Or there can be inadequate excretion, like in states like primary adrenal insufficiency, inhibition of the renin-angiotensin system, that can be because of AC inhibitors, ARBs, mineralocorticoid receptor antagonists like eplerenone or spironolactone, and ENaC channel inhibitors like amiloride. Or there can be decrease in distal delivery, that is, the perfusion that have been affected, in case states like congestive heart failure or volume depletion, or in renal insufficiency, which can be manifested in the form of AK on CKD or CKD state. And type 4 RTA can cause hyperkalemia, but it is important to know type 1 and type 2 will cause hypo, it will be low. In patients with a ureterogenostomy, the rise in serum potassium can occur in patients with a urinary diversion procedures. This is usually concomitant with metabolic acidosis. And drugs like heparin and cotrimoxazole can also lead to hyperkalemia. So mechanism of cotrimoxazole related hyperkalemia is it blocks the sodium channels in the distal nephron, inhibiting potassium secretion. This is very important to know in patients who are receiving cotrimoxazole. Either they may be receiving it for PCV prophylaxis or patients with a long-term ICU stay, they may be receiving it for multi-drug resistant organisms like Stenotrophomonas, where monitoring for this is essential. And pseudohypokalemia can be like in the form of in vitro increased levels of potassium that can be associated with in vitro hemolysis, or in vivo it can be because of thrombocytosis, erythrocytosis, or leukocytosis. So we have seen about the etiology for hypokalemia. It can be because of decreased intake, redistribution into the cells, and increased excretion. And hyperkalemia can be because of redistribution out of the cells, inadequate excretion, and pseudo hyperkalemia. So the next is about the clinical manifestations of hypokalemia. So the important manifestations are in relation to the muscle, the neurons, the heart, and the GAT. So the result In relation to the skeletal muscle, it can lead to muscle pain, which can be generalized with presence of cramps. Especially if it is severe, that is, the potassium is less than 2.5, it can lead on to myopathies and that can lead to rhabdomyolysis. With regard to the intestinal motility dysfunction, because it affects the action potential, it can lead to inadequate depolarization of the gut motility, thereby leading to gastroparesis, paralytic ileus if it is involving the small bowel, and acute colonic pseudo-obstruction if it is involving the large bowel. With regard to the CNS, it can cause hyperpolarization of the skeletal muscles, impairing the capacity to depolarize and contract, leading to weakness, and that can lead to paralysis. And paralysis is usually generalized. With regard to cardiac, the arrhythmias are the most common manifestations can be atrial, ventricular, or precipitate as a form of QT prolongation. And in already vulnerable patients, if the QT prolongation is high, it can precipitate a torsades de pointes. So it is important to correct it at the earliest. The important thing is it can predispose to digoxin toxicity because there is a competition between the digoxin and potassium for shared binding sites in the cardiac sodium potassium ATPase subunits. So the important thing to notice about the ECG changes. So there will be a prominent U wave, which will be more than 1 mm in height, flattening and inversion of the T waves, and prolongation of the QT interval with ST segment depression. So I would personally suggest everyone to take a snapshot of this so that during the exam revision, it would be very much helpful. So with regards to the clinical manifestations of hyperkalemia, again, it can manifest in a cardiac symptoms and signs, the most common being arrhythmias, which can manifest as conduction blocks, VT, VF, bradycardias, or asystole. So it can produce irregular force and rhythm of cardiac contraction sensed by the patient manifesting as palpitations, or because of this cardiac arrhythmias, there can be inadequate cardiac output, and that can lead to fatigue, giddiness, and syncope. So the usual manifestations is peak T waves. There can be P wave flattening, PR prolongation, and a wide QRS. So this is a very, very important table, and this is very commonly asked in practicals. They will ask you, once the ECG is kept and you diagnose it, they will usually ask the serum potassium levels and the associated ECG signs that can be elicited. So between a potassium level of 5.5 to 6.5, there will be usually repolarization abnormalities, which can manifest as peak T waves. Between 6.5 to 7, there will be progressive atrial paralysis, where there will be P wave flattening, PR prolongation, and eventually P waves disappear. Between 7 to 9, there will be conduction abnormalities, which can manifest as bradyarrhythmias. That can be sinus brady, AV block, junctional blocks, and prolonged QRS can eventually set in. In more than 9, all three forms of problems can occur: repolarization abnormalities, atrial abnormalities, and conduction abnormalities. So that will eventually lead on to the sine wave appearance, which can later lead on to VF, or it can go on to asystole or PEA. So the first thing is in relation to the T waves, the second is in relation to the P and PR, the third is in relation to the QRS and the and the rhythm and rate. And the last one is a combination of all. So that will give rise to the sine wave pattern. So in relation to the skeletal muscle, there will be a decrease in conduction impulse, which can lead to muscle weakness and paralysis. And in the renal system, because less hydrogen is excreted due to hyperkalemia, In the proximal tubules, it will interfere with the glutamate deamination, leading to increase in ammonia and acidosis. In the principal cells of the distal tubules, there will be reduced sodium reabsorption, leading to decreased H plus excretion. So as a result of which, more acid is retained in the body, and that can lead to metabolic acidosis, and that can lead to dyspnea. So from a symptomatic standpoint, in relation to hyperkalemia, there can be cardiac involvement, CNS involvement, and musculoskeletal involvement. And dyspnea is one of the common manifestations of hyperkalemia if it is associated with metabolic acidosis. So, with regard to diagnostic evaluation for hypokalemia and hyperkalemia, now the one thing I wanted to do is the best way for evaluation is given in Harrison's. But the problem with the evaluation that is given in Harrison's is it is too elaborate and it is very difficult to remember most of it from an exam standpoint. If you're practicing it on a regular basis in the bedside, you can look at it and then you can send investigations accordingly. But unfortunately, in the exam, for the 10 to 15 minutes you have for preparing a question, you will not be able to remember most of the things. So I've taken bits of what is needed from Harrison's and I've combined it with the things that was given in Paul Marino's so that you will get a better idea and you can easily apply it at the bedside also and from an exam perspective also because from an exam perspective, there are certain tests which we won't use commonly in a critical care practice. So I have not gone in depth into those factors, but whatever is needed, I have definitely covered. So, in regard to hypokalemia, first thing is you assess whether the potassium is less than 3.5. The next thing is you check whether it is an emergency, whether there are any clinical manifestations, which can be cardiac, which can be neuro, which can be skeletal muscle disorder related. So if none of them are there, or if any of them are there, you go for treatment. Whereas if you feel it is a pseudo hypokalemia, then you don't need to work up further. But if it is not an emergency, nor is it a pseudo hypokalemia, then you need to work up. So under the history, physical examination, and initial labs, the first thing you need to look for is the history. So you look for factors of decreased intake or any factors that is contributing for region distribution into the cells or there is increased in secretion or excretion. So if you find that there is a clear evidence of low intake, like patients are with starvation or they have an underlying malignancy and because of which they are cachexic or they have features of anorexia nervosa, you treat accordingly and reevaluate. Similarly, if there is evidence of transcellular shifts, that's redistribution, then you treat accordingly. If both of the features doesn't seem to be significant, then you need to further go ahead with the investigations. So the important thing to look into is the urine potassium. So the urine potassium cutoff is 30. So if it is less than 30, that means that there is less potassium being excreted in the urine. So in that scenario, it is likely to be a non-GI, non-renal cause, which can be diarrhea related most commonly, or it can be because of vomiting and probably skin losses also, like persistent sweating and because of a high sympathetic activity. Whereas if the urine potassium is more than 30, then ideally we need to assess for renal losses. So one pathway is you can, from this point, you can go with the urine chloride and assess if it is less than 15 or more than 25. So if it is less than 15, there is low chloride in the urine. So it must be high likely it can be because of nasogastric drainage. That's either vomiting or there is continuous aspiration or there can be metabolic alkalosis. So low urine, there is high urine potassium with low chloride, then that can indicate metabolic alkalosis. Whereas if the urine chloride is also high and urine potassium is also high, it is high likely attributed with diuretic or magnesium depletion. So this is one way of assessment. But if at all the urine potassium is high, along with the urine chloride, you also need to check the transtubular potassium gradient. So the easiest way to remember is you have to remember the urine and blood potassium and the urine and blood osmolarity. So in the numerator, you will have the potassium, that is the urine by the serum, and in the denominator, you will have the osmolarity, where it will be urine divided by the serum. So when you put the osmolarity in the multiplication format, then the serum will come up and the urine will come down. So the important thing to remember is in TTKG, the two parameters you will look into is the potassium and the osmolarity. And if the value is more than 4, then it indicates a renal potassium wasting. So if renal potassium wasting is present, then you need to look into renal causes predominantly. So there is a, if you look into Harrison, there is a big workup for this alone, but in the exam, you will not have that much of time to write all that. So you can just make a gist of everything together in the form of renal secreting tumors, malignant hypertension, Conn syndrome, Cushing syndrome, Gentleman, Bartter, and proximal or distal renal tubular acidosis. Whereas if the transtubular potassium gradient is less than 2, it means that the flow is good. That is, the tubule flow is good. There is no impairment that is seen. So that can be related to osmotic diuretics like mannitol. As for evaluation of hyperkalemia, you assess if the potassium is more than or equal to 5.5. If it is present and you see there is ECG changes, you go with immediate therapy. Whereas if you see that it is more likely pseudo hyperkalemia, then you don't take any further actions. Like I said, if there is an in vitro hemolysis, leukocytosis, erythrocytosis, or thrombocytosis, you look at the clinical picture and you feel that there is no evidence suggestive of hyperkalemia, then you wait and watch. If it is not life-threatening or then you don't see there is evidence of pseudo hyperkalemia, then you go for a workup. So you go with history, physical examination, and basic labs. So you assess if there has been increased intake of potassium solutions because many patients would have been started on oral potassium chloride or they would have been on IV infusions that might have been given in large quantity. So if that is the case, you have to stop it and you assess the scenario. If there is any clinical manifestation suggestive of it, then you need to treat accordingly. You also assess simultaneously for any factors of cellular shifts or distribution out of the cells, like I told, like in the form of acidosis or patients on any drugs like beta-2 antagonists, heparin, and you assess the clinical scenario and take a call whether it needs to be stopped or any other alternative medication can be used. If either of them is not there, then you go for the next workup. You check for the urine electrolytes. So in hypokalemia, you saw the urine potassium, the urine chloride, and the TTKG. So if the urine sodium is less than 25, then it indicates decreased distal sodium delivery. So decreased distal sodium delivery can be because of hypovolemia or reduced effective circulatory volume in form of low cardiac output state or liver failure. That's in form of chronic liver failure. And in this case, you have to also assess the TTKG. In hypokalemia, the limits were 2 and 4. So the easiest way to remember is in even numbers, 2 and 4. If more than 4, it indicates increased renal excretion. And if it is less than 2, it indicates that the patency is good. So it must be because of any osmotic diuresis. Whereas here the cutoffs are in are in uh, different numbers, that is 5 and 8. So if it is more than 8, it indicates a reduced tubular flow. And if it is less than 5, it indicates reduced distal potassium secretion. So under reduced tubular flow, it can be because of advanced kidney disease where GFR is less than 20 or a reduced cellular volume. So similarly, if urine sodium is also low and TTKG is more than 8, then it can go into favoring reduced extracellular volume. In cases of advanced kidney failure, usually the urine sodium is usually on the higher side, usually more than 40. So that is an important differentiating point. It will be discussed more in hyponatremia evaluation. Whereas if the TTKG is less than 5, it indicates a reduced distal potassium secretion. And the important differentials to be kept in mind is acute glomerulonephritis, tubular interstitial diseases, mineralocorticoid antagonists like spironolactone, trimethoprim use, and primary adrenal insufficiency. So, re-emphasizing it again, for hypokalemia workup, you need to look into the urine potassium, urine chloride, and the TTKG. The TTKG cutoffs are more than 4 and less than 2. If it is more than 4, it is renal secretion, and less than 2, it indicates patent tubules, and it can be because of osmotic diuretics. Whereas in hyperkalemia workup, from a renal standpoint, workup, you need to look into the urine sodium. Then you need to look at the TTKG. So here the TTKG cutoffs is more than 8 and less than 5. So if it is less than 5, then you need to assess for reduced distal potassium secretion, which can be because of acute glomerulonephritis, tubular interstitial diseases, mineralocorticoid antagonists, trimethoprim, and primary adrenal insufficiency. So coming to the treatment of hypokalemia, the goals are to prevent or treat life-threatening complications like arrhythmias, paralysis, abdominolysis, or diaphragm weakness. To diagnose and correct the underlying cause and to replace potassium deficit. So that is actually the mainstay of treatment. In mild hypokalemia treatment usually produces no symptoms except in patients with heart disease. That is, they may be on digoxin or antiarrhythmics or patients with cirrhosis, where low potassium can increase the ammonia generation and promote generation of hepatic encephalopathy. So in patients with GA losses are treated with potassium chloride, especially if metabolic alkalosis is present, as concomitant chloride depletion is also seen. So the treatment is usually 10 to 20 milliequivalents given over 2 to 4 times a day. That is 20 to 80 milliequivalents per day, either oral or nasogastric. So the usual rationale is if you give an oral dose of 40 to 60 milliequivalents, it helps to increase the serum potassium by 1 to 1.5 milliequivalents per liter. But if the patient has acute diarrhea or GI intolerance, IV replacement is recommended. Why? Oral syrup, that is KCl syrup, is supposed to be very high, so hyperosmolar, and that can precipitate diarrhea. And also because it is an hyperosmolar agent in patients who have already an ileus, it can worsen the bowel distension because it will cause increased absorption of fluids from the surrounding extravascular, extra interstitial spaces. So that itself can increase the bowel volume and it can precipitate ileus. So in those scenarios, it is important to correct it with intravenous solutions. So in patients with renal potassium wasting, that is in the form of primary hyperaldosteronism like Conn's disease or chronic diuretic therapy, potassium supplements only produce modest increase in serum potassium. So in these scenarios, it is also important to supplement potassium sparing diuretics like ENaC blockers, like amiloride, that is given at a dose of 2.5 to 10 milligrams per day to a maximum of 40 milligrams per day, which is increased gradually over a week. And mineralocorticoid receptor antagonists like spironolactone or eplerenone can be given. For both, it started at 12.5 milligrams and it can be increased to a maximum of 25 milligrams, sorry, 50 milligrams a day. That is 25 milligrams in 12th hourly or BD can be given. With the important thing is that serial potassium and creatinine monitoring has to be done. So if the creatinine is more than 2 or the potassium is more than 5, that becomes an indication to stop MRA antagonist treatment. Sorry, mineralocorticoid antagonist treatment. But in cases with moderate to severe hypokalemia, potassium must be given more rapidly, especially if they are symptomatic. So the mainstay is to go with intravenous potassium chloride, which can be given as an adjunct to oral replacement, provided there is no GA symptoms. The alternative to this is supplementation of potassium phosphate, which is usually present as a 15 ml solution that contains 66 milliequivalents of potassium. So with regard to IV potassium chloride, it is available as a concentrated solution. That is, each ml contains about 1 to 2 milliequivalents in ampules containing about 10, 20, and 40 milliequivalents of potassium. It is very, very hyperosmolar. So the important thing is it should be diluted because 2 milliequivalents per ml contains about 4,000 milliosmoles per kg. So it is very supposed to be very very big irritant to the vasculature, especially the veins, if it is administered through the peripheral route. And in cases of hypokalemia, it is important to be administered in a non-dextrose containing fluid like half NS or NS because dextrose itself will further stimulate insulin and that itself can cause further decrease in potassium. Even though it is theoretical, from an exam standpoint, it is very important to know about this. And continuous telemetry is very, very important during administration. So there are certain cutoffs. So if it is given via peripheral vein, in 500 ml, the maximum potassium chloride that can be given is 40 milliequivalents. If it is given in 1000 ml, the maximum is 60 milliequivalents. And if it is given in 100 ml, the maximum is 10 milliequivalents. Whereas if it is given via central vein, in 100 ml, the maximum administration is 40. In 250 ml, the maximum is 60. And the maximum rate of infusion is only 40 milliequivalents per liter. It is very, very important to know. More than this, potassium infusion should not be given because there is the maximum infusion rate is 40 milliequivalents per hour. It's my bad. It's not 40 milliequivalents per liter. It is 40 milliequivalents per hour. Because more than this rate, if it goes, there is a high predisposition for patient to go into cardiac arrest. So with regard to the treatment of hyperkalemia, the first important thing is if at all there is symptomatic features present like ECG changes, the first important thing is to immediately antagonize the cardiac effects of hyperkalemia. So IV calcium is the most important drug. How it helps is it increases the cardiac action potential, it reduces excitability without changing the resting membrane potential. It restores the difference between the resting and threshold potentials and reverses depolarization block due to hyperkalemia. So these are the four important mechanisms how calcium helps in stabilizing the cardiac uh, rhythm. So it can be given as calcium gluconate or calcium chloride, but most commonly calcium gluconate is used. That is 10%, 10 ml over 10 minutes. So it has an onset of 1 to 3 minutes with a duration of 30 to 16 minutes. Whereas if a circulatory shock is present, then 10% of 10 ml of calcium chloride can be given as low IV, but it has to be given only via a central line because it is highly hyperosmolar. The important thing to notice if the patient has developed a digoxin toxicity, calcium can further potentiate it. So it should be preferably avoided, but in circumstances where it is really needed, it needs to be given very much in caution. So there needs to be continuous monitoring with backup for other cardiac medications. So the first one is in relation to the membrane stabilizing effect. The second is rapid reduction of plasma potassium by redistribution of the cells. For this, we have various modalities. The first one is insulin. So the textbook recommends to give 10 units of regular insulin followed by 25 grams of IV dextrose, that is 10 ml or 25% dextrose. The onset is usually 15 minutes and the duration is 4 to 6 hours. So if sugars is usually more than 250 milligrams per deciliter, insulin is administered without glucose with close monitoring. 50% dextrose is not recommended because it is hyperosmolar and usually hyperosmolarity itself can further precipitate hyperkalemia. Then beta-2 agonists like salbutamol or levosalbutamol can be used. For salbutamol, the dosing they say is 10 milligrams. Usually the recipients contain 2.5 milligrams. But here in cases of hyperkalemia, you need to give it 10 milligrams nebulized over 10 minutes. So the onset usually occurs within 30 minutes and the duration is therefore 2 to 4 hours. So the only concern is because it's a beta agonist, it is both associated with hyperglycemia and tachycardia because there will be, so, even though it is specific to beta 2, there will be mild beta 1 and beta 3 activity also. So in cardiac patients who already have severe LV dysfunction where tachycardia may not be well tolerated, it needs to be used with caution. The important thing is beta 2 agonists should not be administered alone because especially in patients with ESRD, they may be resistant to the beta 2 agonist. So it is always important to co-administer with insulin. So when you're writing an order for hyperkalemia management, both an insulin dextrose and beta 2 agonist has to be written together. The next is IV sodium bicarbonate, which can be given as 50 to 100 milliequivalents, or IV direct bolus if there is a central line, or 150 milliequivalents in 1 liter of either 0.45% normal saline or 5% dextrose over 3 to 4 hours. It has a variable onset and duration, but currently there is no role in acute management of hyperkalemia because it has more side effect profile like hypernatremia, volume overload, and hypertonicity. So this has been taken from Harrison 21st edition just for reference for you all. But can it be used in any other scenario? Yes. If at all there is a concomitant metabolic acidosis in the background of AK, then you can keep it for correction of both acidosis and hyperkalemia in the form of an isotonic solution. So we had spoken about membrane stabilization effect, redistribution into the cells, and then next is removal of potassium. So you can go with calcium or sodium polystyrene sulfonate that are cation exchange resins. So they help in increasing the stool potassium excretion, which helps in exchanging sodium for potassium in the GI tract. So it is usually given in a dose of 15 to 30 grams every sixth hourly with an onset of 1 to 2 hours and the peak action occurring at 24 hours. The very important thing to note is it should be avoided in patients with ileus or constipation because there is a very high risk of intestinal necrosis. Loop diuretics, 40 milligrams IV start with subsequent dosing based on the clinical status can be given because it has an onset of 5 to 10 minutes and a duration of 2 hours. It can be used in the event of volume overload if it is symptomatic because it will have an additive effect because it will help in decreasing the volume status and it will help in removal of potassium. But the important thing is it should not be used as a sole agent. Similar to beta 2 agonist, it has to be clubbed with another modality like insulin and dextrose solution. In patients with the refractory hyperkalemia, and that is despite all the possible medical therapies that are given, and even after cessation of the precipitating factor, like any possible drug use that are being given, if there is persistent hyperkalemia that is related to any kind of hemodynamic or neurological deterioration, that becomes an indication for hemodialysis. So hemodialysis is actually the most effective method of potassium removal. So, as you might have already heard about it or read previously, under hemodialysis, there are only three important life-threatening indications. One is refractory hyperkalemia, one is oligonucleotide volume overload, and persistent acidosis despite correction of the underlying cause or supplementation of bicarbonate. So, refractory hyperkalemia is a definite indication for hemodialysis. Thank you.